EXSCEL was the cardiovascular outcomes trial for the once-weekly GLP-1 receptor agonist exenartide. So 14,752 subjects were randomized to receive either once-weekly exenartide or placebo, and then followed up with visits every 6 months to evaluate their cardiovascular outcomes. The analysis we did here was specifically looking at subjects in EXSCEL that picked up an SGLT2 inhibitor as part of usual care during the study. So we used this subset of subjects to look at our subjects taking both exenartide and an SGLT2 inhibitor during the course of the trial and studied their outcomes as compared to those of subjects that took exenartide but not an SGLT2 inhibitor, or subjects in the placebo arm who did not take an SGLT2 inhibitor, so they were exposed to neither a GLP-1 agonist nor an SGLT2 inhibitor. In our analysis here, what we found after propensity matching these sets of cohorts so that we had equivalent subjects that we could compare taking both exenartide and SGLT2 inhibitor to either exenartide or to placebo, so neither agent, was that we saw a numerical trend for reduction in major adverse cardiovascular events, and that point estimate was a little bit lower compared to placebo than exenartide. So this suggested that there may be some additional effects of combining these GLP-1 receptor agonists and SGLT2 inhibitors. Now, these effects were not statistically significant, which is what we would expect because this is a post-hoc analysis, so it wasn't powered. And also the size of the cohorts were fairly moderate, about 570 subjects in each arm in the two comparisons. So this trend was interesting, though, because it fits with the idea, the hypotheses that because these mechanisms are different, maybe putting them together would provide additional benefit. And we do know we see additional risk factor improvements there. When we broke into that MACE endpoint, which is a composite of cardiovascular death, non-fatal MI, and non-fatal stroke, we saw that improvement was specifically in cardiovascular death. So we saw a nominally significant reduction in cardiovascular death with this combination, and also a nominal reduction in all-cause mortality. On the renal side of things, what we looked at was eGFR slope. So in this population, we don't have very many patients progressing on to end-stage renal disease, so eGFR slope is something we can look at to capture that progressive decline earlier on in a population. And when we do that, we see that in both comparisons, so compared to exenartide alone or compared to placebo, subjects taking this combination of exenartide and an SGLT2 inhibitor had improvement in eGFR slope of about 2 mils per min per year. And so we could actually see over time, before taking the SGLT2 inhibitor, this gradual decline in eGFR slope that we expect with age. And when they add the SGLT2 inhibitor, we can actually see that slope flattening out. So the similarity in these two comparisons suggests that most of what we're seeing here in this relatively renally healthy population is likely the SGLT2 inhibitor effect, which looked consistent on top of either exenartide or placebo. So here we have data on subjects taking both a GLP-1 receptor agonist, exenartide, and open-label SGLT2 inhibitors. And this is the first data to date on clinical outcomes in subjects taking both of these classes of drugs. So that's the main new thing here. When we look at existing cardiovascular outcomes trials for these two classes of drugs, we've seen multiple agents that have cardio and or renal protective actions, though the results vary between the two classes and between trial to trial. So in this case, we have the open-label SGLT2 inhibitor use, which is a little bit different than in a cardiovascular outcomes trial, but it does give us an opportunity to look in the specific cohort at these outcomes. So this analysis was very much hypothesis generating. It wasn't powered, and we do need to keep in mind when we do this propensity matching approach, which allows us to account for the non-randomized SGLT2 inhibitor use, and making sure we have equivalent subjects we're looking at that took the combination and making sure we compare them to subjects that are very similar on laboratory values, medical history, demographics, that sort of thing in our comparator groups. So that gives us an opportunity to look at causation and the effect of this combination. However, it does mean our results really apply specifically to that population in this trial that are choosing to take an SGLT2 inhibitor. And we have to remember that while we're doing our best to match these cohorts, anything we don't measure and control for could introduce unmeasured confounding. So in this case, this is exciting, interesting new clinical data on these outcomes, which we haven't had before. But it's really a first piece of evidence. It supports the hypothesis that this combination may provide additional benefit and motivates the the collection of future additional data, but we really will need more data to have definitive ideas of what the outcomes are with this combination. So this analysis, while hypothesis generating, really motivates and supports the hypothesis that this combination of a GLP-1 receptor agonist and SGLT2 inhibitor may provide additional benefit, particularly on mortality, where we may see these different mechanisms coming together. But since it's very much hypothesis generating, the main outcome we hope is motivation for additional study and additional collection of clinical outcomes in these populations to better understand how these two classes of drugs are working together to affect cardiorenal risk.